Hi, everyone, and welcome to ADIA's second webinar of six for 2025. And just a quick note, too, that on May 21st and June 4th from 6 p.m. Eastern Standard Time till 9 p.m. Eastern Standard Time, I will be running the Implant Coordinator Certification Program for anyone that is looking to expedite their fellowship or working on their master's. This will be an excellent opportunity because we're not doing anything live in 2025, but in 2026, we're going to be doing Vegas in October of 2026. So I hope to see all of you there. Without further ado, I'd like to introduce our guest speaker for this evening is no other than Lynn Pencek. I had the privilege and the honor of meeting her last year in Orlando as she spoke for our association, did such an amazing job that we knew we wanted her to be a part of this platform with us as well. So Lynn, without further ado, I'm going to let you take over, talk about yourself, do whatever you need to do. And thank you so much for being here with us this evening.
Thank you so much. Please confirm you do see my slides.
Yes.
We're good? Awesome. Everybody, thank you so much for spending Wednesday night with me. My name is Lynn Pencek. I am a dental hygienist. I am obsessed with implant maintenance. And our name of our class today is Implants, Parts, Pieces, Chemistry, and Compatibility. So little disclaimer, I'm going to share with you, I do have some relationships with corporate sponsorship. These companies help me when I present at dental hygiene conferences. This whole presentation wouldn't be possible without the generous help of the sponsors I have listed here on this slide here. And Young Dental actually helped me with financial support for putting this class together. So we want to thank for Young Innovations. Here's my background. I live in Philadelphia. I am a graduate from SUNY Broome County Community College. I have a 4-year degree from Thomas Jefferson University and a master's from University of Maryland. So I've spent most of my time in the Northeast. I fell into a sales position with Oroscoptic. I sold loops for 25 years. The Loop Company and Nobel Biocare were part of the same company. I would do events with Nobel, and a territory opened up for the implant territory opened up in South Jersey, and I transferred from working with loops to working with implants. And now that I'm getting a little closer to retiring, I'm back in clinical practice seeing patients, and I'm doing some research, writing, and presenting on implants. So that is my background. This is my family. This is my husband and my 2 Basset hounds. And I sleep with and vacuum up after these 3. We live in Philadelphia, and the reason this picture of Philly is green, not because it was St. Patty's Day, but because the Eagles won the Super Bowl. And just want to tell you, Philly does it right. 1 million people came to the art museum, those steps Rocky ran up. 1 million people came to celebrate the Super Bowl win. And I've got to tell you, Philly's just such a cool place. Please let me know when you're in town. I'd love to take you out and about. So how did I get where I am? I took a position with Nobel Biocare, and I went through some pretty intense training to become an implant rep. So I wanted to share with you my graduation picture when I received my certification from Nobel. And it wasn't just on implants, but the surgical planning and all aspects of working with implants. And I found myself very overwhelmed because it wasn't just Nobel I was learning about, but it was the entire corporation of Invista. So Invista has the companies such as Gendex, Itero. It's not just digital imaging, it's 3-dimensional scanning. It's the software DTX to plan the surgical cases, the actual surgical workflow, the restorative components, the laboratory components, the digital workflow and communication between the two. You understand, this is a lot that I learned about. And honestly, with this whole flow of placing and restoring implants, my questions were, what do we do after when they're in the patient's mouth? What do I do as a hygienist? And working with Nobel, basically it's the restoration is where their business model ends. And I think Nobel should take on companies such as a laser and air polish and ultrasonics. So I wanted to learn more, and I wanted to find community, and I became a member of ADIA. And I'm just really thrilled to be part of our community. And please, my phone number's at the bottom of all of my slides, my email address. If you have any questions, take a picture, reach out to me after the class, please, please. All right, here's our objectives tonight. We're going to review the history of osseointegration. We're going to identify the components for single tooth and full arch concepts. We're going to review the maintenance protocols to prevent peri-implantitis. We're going to talk about biologically safe instruments and materials to use on implants, and we're going to identify home care products and techniques that are safe. Now, the reason I put this class together is me as an implant rep, I would visit oral surgeons and they would hand me an envelope with an implant. that failed. It was in a patient and it came out. And it just didn't, the oral surgeon wasn't too concerned about it. He says, it happens. I place the implant. I don't see the patient again until it fails. Here it is 30 years later. Not a lot of implant cases fail, but my question was, why does this happen? And how do we communicate better about it? And it turns out us in implant dentistry, everybody works in this little micro environment of our practice, and each practice is very different. And our practices can be different based on the year we received our education. Was there a residency? Who were our faculty in the residency? What was the discipline? Surgery, prosthetics, periodontics, they all function and think about implants very differently. Experience. Do I have somebody who's very, very experienced and is working with techniques that are older? Do I have somebody very young with state-of-the-art education, but not a lot of experience? Then there's workflows and what laboratory you're working with and your supportive staff and your continuing education, your community, your mentors, your study groups, what implant company you're working with. So all of these factors give us a very different experience in what we're doing in our private practices. And so what I learned was the communication about the knowledge between our disciplines does not always transfer well in regarding maintenance. I found the periodontists thought very differently than the oral surgeons, and the restorative doctors thought very differently. And what I've learned is there's been a profound shift in the management of peri-implant disease. And there's materials and techniques that we previously thought were appropriate to debride and to regenerate infrabony defects that now has been proven harmful to the implant surface. So there's reason to believe that what we may be doing may be causing more damage than good. So classes, when I teach basics in maintenance, I really focus in on assessment and home care. We're going to really focus on the maintenance aspect and the biocompatibility of the materials we work with. So we're going to get real heavy into chemistry and science. But first, let's talk a little bit about history. So Professor Brandemark in 1952 discovered osseointegration by accident. He was actually an orthopedist. He was looking at circulation of blood flow on a rabbit femur. He had a viewing glass encased in titanium. And at the end of this study, it was time to remove the titanium cast from the rabbit's femur bone, and he couldn't. The bone became infused and became one, ankylosed, with the titanium. So if we look at the periodic chart, we have two materials that are biocompatible. Titanium, pure titanium, class 4 titanium. You can also work with titanium alloys, and you'll find titanium alloys can be nickel or aluminum. Or you have zirconia, and it's not zirconium, the metal, it's zirconia dioxide, and it's actually a ceramic. So the titanium and the zirconia dioxide are the two materials that you find are biocompatible that we use in implant dentistry. So the implants can be made of pure titanium, or they can be made of an alloy. And class 4 titanium, pure titanium, is more corrosion resistant. So class 4 titanium is the metal of choice, but you will find there are implants that are made with the alloys, and you'll find that these implants may corrode more. So pure titanium, more corrosion resistant. And when we look at the implant surfaces, the surface of the implant has changed over time. So over years, we try to improve for better biocompatibility, faster osseointegration, better tissue responses. So you'll find different thread designs, different collar designs. And the implant surfaces can be rough. They can be minimally rough. There's a difference. They can be machined. It comes out of the machine with a certain texture, or they can be polished, very smooth. So we're looking at how do they create these type of surface textures. They can be machined, sandblasted, laser etched. They could be anodized. We can use fluoride. We can use hydroxyapatite. And what we're trying to do is create the outermost surface of the titanium into a dioxide layer. We're trying to increase the surface chemistry for better osseointegration. So there's two different ways we can do this. It can be reductive. So we have the implant come out of the machine, and now we're trying to create more surface texture. And we can do that with sandblasting. So the process involves getting abrasive particles and etching on the outside surface of the implant. The benefit is it creates a nice rough surface that increases the amount of surface texture for the bone and for the blood proteins to attach and integrate with the implant. We can work with laser treatments, and laser technology creates these micro and nano surface textures. The benefit here is we have better control and precision in creating the topography, which improves our cellular response. Machining, we can also work with additives. So instead of removing surface texture, we can give additional chemistry to the surface texture, one of which is using hydroxyapatite. And the hydroxyapatite will naturally encourage the mineralization of the bone to the implant. It's got great biocompatibility and promotes bone growth. Plasma spraying creates that implant layer of the titanium and the hydroxyapatite. Fluoride is a very inexpensive way of creating the surface texture. And it stands out simply because it's cost effective, and the additive benefits also better compatibility. Stannous fluoride gives better antimicrobial benefits. So fluoride's an interesting topic we're going to go into. And then there's anodization. And anodization is the introduction of the titanium into an electromagnetic process. We take the implant, we place it into an acid bath, we give it some electricity, and it creates this nano surface texture. It creates a rough surface to promote better bone integration. And we notice with anodization, the titanium surface texture will change color over time. So the amount of time of anodization, you may find the color changes to gold, to pink, to blue. And we find in implant dentistry, one company has a pink anodized implant, and they say that it gives a nice aesthetic because it blends in with the soft tissue. We have a gold aesthetic with the anodization, and we found the surface chemistry with the gold anodization gave better biointegration, faster osseous integration, faster mucal attachment. So we actually have a faster response. Then we have also in the implant instruments, the titanium tipped instruments, some, not all, some are anodized and they're colored tips, which draw attention that it is a titanium tip. This way we know which instruments are stainless steel versus titanium. Then also, you may find that the colors in anodization may be used to indicate the size of the abutments, the impression copings, or even the locators. So let's talk about this layer of anodization, this layer of creating micro roughness. Titanium dioxide is considered a corrosion layer. The corrosion layer enhances the dental implant surface characteristics. This process involves modifying the implant surface to increase its roughness and its surface energy, which aids into the better bone integration. So we're going to call this good corrosion, titanium dioxide. We're going to call it good corrosion. And what I have here is some examples of different surface textures in corrosion. And I wanted to give the visual of what happens when our pipes, when they get exposed over time. So here's the benefit. By increasing the surface energy of the implant, it becomes more hydrophilic and it promotes better cellular attachment. So if I have assistants on the call and they've been in surgery, they may have noticed when they place the implant into the osteotomy, the blood proteins may work their way up the threading of the implant. So we call this being hydrophilic, and this is a very interesting factor in creating a faster, more successful osseous integration. Very interesting change in technology. And it's not just anodization. The picture on the right is actually a zirconia implant that also demonstrates the hydrophilic property. Some implant companies work with zones of roughness. So you may find that the implant's more rough at the apex because we want to get that locking. We want to have that integration of the implant into the cortical plate. We'll have moderate roughness in the body of the implant. We may have smooth surface at the collar. So you may find these zones of roughness or transition, giving better osseous integration. Now let's talk about this from a dental hygiene standpoint. Dental hygiene's changing, and we now have two different schools of thought for instrumentation for implant maintenance. One school of thought is to reduce biofilm with minimal abrasion to the implant surface. We work with a sterile saline on a cotton pellet. We're going to remove biofilm, gently cleaning with a cotton pellet. Maybe use the curette, but we're going to use it more as curettage and use the metal blade to take away infected tissue, and in some cases, chlorhexidine mouth rinse. This is a very old school way of maintaining implants. So originally, when we heard about maintaining implants, you hear, you barely want to touch the implant. The less you touch it, the better off you are. So this is a very conservative method. The rationale here is that if we work onto the implant surface, the titanium particles can be associated with a peri-inflammatory disease, which means that the particles can be released. Think about the corrosion layer, and that if you flake off it, if you're putting your hand on a rusty pipe, you can gently brush off the corrosion. The thought here is that using instrumentation may liberate little pieces of titanium ions into the soft tissue and create inflammation. So the thought here is minimal pressure could cause the release of these titanium ions. So with this thought, we refer to this disease, peri-implant disease, as metallosis. And metallosis was actually identified in orthopedic surgery. It's considered an inflammatory result to the titanium particles. In orthopedic surgery, we'd have titanium particles inside the body, and there would be inflammation inside the body. So we found that even not with what we do as dental hygienists releasing the metal particles, but the metal particles could be released, say, during the placement of the hip replacement. And then we have this inflammation inside. So the disease of metallosis, inflammation as a reaction to metal particles in the soft tissue. There's also a term called tribocorrosion, and this is exposure to both acid from the mouth as well as mechanical forces causing the breakdown of the implant body, releasing the particle release. So the acids in the mouth could be caused by biofilm. The acids could be caused by food, eating foods that are very acidic, or by oral hygiene products. So we need to be careful about the acidity of what is consuming into the body. So what else do we identify with creating metallosis? Corrosion, which we've talked about, micro movement, physical trauma during the hygiene phase of debridement with hand scalers, ultrasonic scalers, or piezos. So we have to be very careful. So that philosophy of the less we touch the implant, the better off we are, has a lot to be identified with. Second school of thought, this includes manual instrumentation, sonic or ultrasonic scalers, air polishers, airflow. And all of this is necessary to remove biofilm, regardless which way we go apart with teaching our patient, with removing biofilm from our patient. If there's inflammation, we should bring our patient back to see if this is cleared up. So if there is any remaining evidence of peri-implant mucositis, this may require more aggressive therapy. So let's look at what are we working with our patient, what are we using on our patients? A review of bacterial colonization caused by various dental hygiene instruments. Conclusion, no single instrument could be considered the gold standard in treating peri-implant disease. And this article states that metallic instruments should be avoided on titanium implant surfaces due to the risk of damage of the implant surface. I'm not saying never use metal instruments, but it should be avoided. So if we do not have inflammation, we should not necessarily be using our metal instruments on these implants. It also says, bacterial infection caused by inflammation around the dental implant is one of the main etiological factors underlying an implant failure. So with all best intentions, we may be doing too much. So the question is, how do we maintain healthy implants? How do we remove the biofilm, protect the attachment of the smooth surface of the implant, prevent exposure of corrosion on rough surfaces needed for mechanical stabilization? It's a conundrum. What are we supposed to do? And the answer is what you don't do may be more beneficial than what you do. So instrumentation should be safe, effective, and efficient. We should not scale with metal instruments on every implant patient. And this is a hard one because I remember with a dental hygiene student. So this was actually the son of a friend of mine who's a dentist, and I was asked to be a patient at the dental hygiene school. And he says to me, we have titanium instruments to scale on the dental implants. And it's like, we don't have to scale all implants. So we need to understand, when do we do this? We really should only use hand instruments to remove visible calculus and more so cement. And we'll talk about cement more. We do not use hand instruments to remove biofilm. A blade will not remove bacterial biofilm. And you really do not root plane implants. So when someone says to me, well, maybe we should root plane around there, they're not understanding the science we're talking about. So the theory here is the less you touch the implant, the better you may do. With best intentions, we may be doing more damage than good. So the question is, where are we working on the implant? So if we look on the left in the healthy implant, the bone goes to the top of the threads and the soft tissue attaches onto the abutment. So in this case here, if the tissue is not inflamed, we may not need to use instruments. We may not need to use hand instruments. If the patient has bone loss, we have threads exposed, we're going to identify how to work with these patients differently. So keep in mind, where are we working on the patient? If this is a healthy patient or if this is a patient with bone loss. So here's what's happening with peri-implant disease. We're seeing more of it. more patients are getting more implants. That means more people are more likely to develop peri-implantitis. It's not that peri-implantitis is becoming a bigger problem. It's that more patients are receiving them. So we're starting to identify it more often. So it's not the percentage of cases that are becoming inflamed. We're just seeing more. And here it is, much public awareness of how to treat peri-implant disease and the risks of the symptoms, delayed diagnostics for patients who do seek treatment. The delay of the treatment could potentially worsen the outcome. So when we're working with implants, the goal is to maintain healthy implants. Our greatest tool to prevent peri-implantitis is early diagnostics and intervention. We want to catch this at the inflammatory stage where we have mucositis and prevent the bone loss from happening and exposing the threads of the implant. So there's a general confusion in general dentistry about what do we do to maintain healthy implants, address mucositis or early peri-implantitis, and how to address moderate to advanced peri-implantitis. This article was published in the British Journal of Dentistry. This article did exactly what I was trying to do, and it was a workflow. So this is the maintenance of peri-implant health in general dentistry, and it is a workflow. Here's what the article explained. With implants, 45% of patients who have implants will experience some kind of mucositis, and mucositis is reversible. So healthy implant, no bone, mucositis, inflamed tissue, no bone loss. 20% of the patients with implants may experience peri-implantitis. So the goal here is if we have inflammation and mucositis, how do we reverse it so it becomes healthy? How do we prevent the mucositis from progressing into peri-implantitis? So this is a workflow, and the workflow gives maintenance protocols. It reviews what it calls supportive peri-implant care, SPIC, and it gives insight to the factors considered when managing implant patients. So this is a nice workflow. I'm going to break it down. Let's cut it down a little bit, make it smaller, easier to work at. If we have a patient who's healthy, we're going to have this patient on a 3 to 6 month recare program, depending on the risk factors. And with patients who are healthy, we're going to perform professionally administered biofilm removal. So here we have healthy patient, control of risk factors, patients aware of home care. We're going to do a clinical evaluation, radiographic assessment. Once a year, we want to see x-rays to make sure that we're not seeing any bone loss. If we're healthy, we're going to maintain health, review oral hygiene. What is the patient doing for daily home care maintenance? We identify risk factors that we may need to control, and then apply professionally removed or professional mechanical biofilm removal. Let's look at this if we have inflammation. Whoop, I got ahead of myself. Sorry, guys. Let's define non-surgical periodontal treatment. Removal of calculus and biofilm, we can work with ultrasonic instruments. We want to work with a coated ultrasonic instrument tip. If we have calcified deposits, we can work with titanium or carbon fiber curettes. Plastic curettes do not have the strength to remove heavy calculus. Biofilm, soft plaque biofilm, use of rubber cup polishers, fine prophy paste, or air polishing devices. So if we have a patient who is inflamed, we're going to do a reassessment. If the patient is healthy, we're going to bring them back into that preventive protocol. If the patient is inflamed, if it comes back after evaluation, the patient is still inflamed, then we want to address this with the patient. So non-surgical periodontal treatment should be provided as an essential step for resolving inflammation. Depending on the response of peri-implant tissues, or surgical treatment of peri-implantitis may be recommended. So we may go through the secondary process, evaluate if the patient's still not healthy, then we want to refer the patient to a specialist. So if we're able to control inflammation, we can keep these patients in our practice, but if the patient is inflamed, we definitely want somebody with more training on treatment of peri-implantitis. So my goal here is, what are we doing in general practice offices? If the patient comes in and they're inflamed, local systemic use of antibiotics for mucositis is no longer recommended. This is interesting because I'll see some periodontal offices still want to work with an antibiotic, place subgingival. We want to now work with probiotics to prevent antibiotic resistant bacteria. So probiotics have become a feature and change in protocols. And the work with probiotic tablets or tablets containing the Lactobacillus rudi probiotic strain. Probiotics offer benefits that potentially help they modulate the oral microbiome, so they can actually help grow the good bacteria in the mouth and promote the immune response, improving inflammation. And we find that the probiotics help within a 3-month period. This is really exciting. Probiotics are really a neat direction of what's happening in periodontal peri-implant health. So probiotic tablets containing the Rudy strain, the bacteria, the L. Rudy ATC bacteria probiotic was found in a Japanese woman with poor oral hygiene, but good gingival health. So this particular probiotic strain was identified. And we've all seen that patient who comes in, they got plaque everywhere, they got schmutz. You go in and you probe, the probe readings are good, there's no bleeding on probing. You instrument, there's plaque everywhere and they're not bleeding and it makes no sense in your brain. This patient has a high amount of the L. Rudy probiotic strain in their oral biome. So we're working now with how do we identify patients who are high risk and now give these patients probiotics. So how do we do this? I work with an office that after biofilm removal will take probiotic drops, put them in a Dappen dish, use a microbrush, and work with a microbrush around the implant. And for home care, the recommendation is we take these probiotic drops, put them on an interproximal brush, and have the patient clean with the interproximal brush and push the probiotics into the area that's inflamed, into the pocket. This is a really great way if you have a prosthetic where an implant's misshaped to fill the to fill the dental space, but underneath the implant you have a large food impaction. So I like working with these proxy brushes for these type of patients. So putting the drops on the proxy brush gives us the two benefits. How do we make it work? Oh, hey guys, this is a QR code in the top right. I'm going to give you a second, take a snapshot of this page. If you work with that QR code, you can receive free samples and schedule a lunch and learn with BioGaia. And the recommendation is go ahead, so take this as continuing education. I will, after this class, have my notes with all these QR codes available after the class. We'll make sure that people get the notes and the QR codes. All right. So our goal is, what do we do the greatest amount of good with the least amount of damage? This was a study by Ivy Zelmer. This came out in 2020. And the question was, what instruments are you using and how effective do you feel? And what I found so interesting was in this study, almost 100% of the respondents had worked with plastic instruments and less than 10% felt like they were effective. And they're right, the plastic instruments can't remove calculus or cement. They're just not strong enough. When we look here, titanium scalers, 2/3 working with titanium scalers, about half of them felt effective working with titanium scalers. And then if we go all the way down to the bottom, the subgingival air polishers, this study is 5 years old. The use of subgingival air polishers has dramatically increased over time with the identification of its effectiveness with implant therapy. And when we look at this group here, small percentage using them, but a higher percentage felt confident that they were effective in what they were doing with the air polishers. So let's go into plastic instruments. I see this and it makes me nuts. The plastic tips on the Implicare was a single-use tip, and you see these tips being autoclaved, and the tips just do not have that type of durability. So the plastic instruments are no longer considered standard of care. And the reason is that there is evidence that plastic scalers leave trace elements of plastic behind on the implant surface. And what we spoke about in the beginning was implant surfaces are rough. Think about taking the plastic instrument against the rough surface of an emery board. You're going to see shards of the plastic left behind. So if we do need to do instrumentation, if there is cement, if there is calculus, working with a titanium instrument will be more biocompatible. So we have two things happening. One is the concern that the instrument may change the surface texture of the implant. This is why we only want to use these instruments when we absolutely have to. And the other is, if we use the instrument against the implant, is the instrument leaving little pieces of metal onto the implant? And if it is, and you're working with a stainless steel instrument, you're leaving stainless steel behind on titanium, which is not biocompatible. So the less you instrument, the better off you are. If you have to instrument, you want to work with something that's biocompatible and effective for the task. Pick the right tool for the right job is what I'm saying. So here we are, hand instruments to work around with calculus or cement, not biofilm. A blade will not be effective in removing biofilm. This is Hybenex. Hybenex and Perio-DT are the same product. Young Dental, Young Innovations is releasing the product of Hybenex. So we have one manufacturer and two different distributors of it. This is not an antibiotic. This is desiccation therapy. This is a hygroscopic solution. It's a water-seeking molecule, and it will denature irreversibly, desiccation, remove all the water out of the biofilm. How does it work? Desiccation shock therapy. Biofilm is mostly water. By applying this acid, it extracts the water out of the biofilm, leaving the bacteria eradicated. So this will reduce the bacterial load, and it will make hard deposits easier to remove off of implants. So this is how it works. These photos are on natural teeth. You will find that the information about Hibenex Perio DT desiccation therapy really geared towards natural teeth. So top left, I have calculus lower anteriors, and I'm taking a gel and I'm extruding it onto where the calculus. We're going to wait 10 to 30 seconds, very short period of time. We're going to rinse the gel off of the teeth, and you can see that the soft tissue is very white around here, and the calculus will come off easier. Then we're going to take the gel, we're going to place it subgingival, 10 to 30 seconds. We're going to rinse it off, and then getting this calculus off the teeth subgingival will be easier. I'll show you what I mean. But here's what's interesting. Working with the desiccation therapy not only removes the water out of the biofilm, it will also help reduce the edematous tissue, and you'll see that the tissue shrinks down and it becomes white. This is a short-term process, but what it does is hemostasis. So it makes visibility and scaling easier too. So not only does it make the calculus easier to come off, but it's also reducing the bleeding and removing the bacterial load. So I have a video. Video's a little long, but I'm going to point out, here we have inflamed tissue. We're looking at probe depths. And our goal here is, how do we remove the biofilm subgingivally? So we got probe depths at around 6 millimeters interproximal. All right, that's about 3. We're starting to see bleeding on probing. We're going to give it a minute. So here we have the gel. Most important step, let's extrude the gel out of the tip to make sure that it's flowing out easy. We're going to dry the area, have a little lip protector there. We're going to place the gel subgingival. We're going to wait 10 to 30 seconds. All right, and we're going to rinse it. We're going to take the high suction evacuation. We're going to remove the gel. We're going to rinse off the rest. And we got to be careful with this. This is an acid. It does not taste good. So we see the white tissue, and we have the ultrasonic working subgingival, and you see that the bleeding's reduced. And we all have been in there where we get all the granular tissue, the clotty tissue, and it's hard to see. But with the desiccation therapy, we're getting the benefit of the hemostasis, and the calculus is coming off easier. This is so exciting. So let's move forward here. I have been saying this is an acid. This is a acenified phenolic acid, a sulfuric acid, and water, battery acid. So we have to be careful with implants because we know acids can cause corrosion. This solution comes in 2 viscosities. It comes in a gel and a liquid. And what I wanted to point out is the gel, very thick. You'll place it on, it'll stay in place. I am more concerned, if I'm going to work with this, it's going to be the most effective. I'm more interested in the liquid form. So if you look at this, we'll put the liquid on the implant. Sorry about the motion in the video, but you see how it just fills in the threads? That's where we want to work with the biofilm. So if I'm going to work with this type of desiccation therapy, I really want to work with the liquids if I'm applying it on implants with recession, with the threads exposed. All right, let's go on to the next picture here. So I don't see desiccation therapy as appropriate for management on a healthy patient or management for mucositis. I see this really more for peri-implantitis, and we're seeing right now the research is more with open flap debridement. And what's happening here is that with these cases, we're getting excellent bone regrowth and we're getting bacterial reduction. And what's happening here is the data is indicating that in controlled chemical oxidation, the titanium implants significantly enhance contact and osseogenesis. So if we're going to graft and we're going to try and regrow bone where there's been recession and threads exposed, this is very promising. So one of these studies was about early loading of implants and working with desiccation therapy at the placement of the implant. Notice, I think that was an oral surgeon. That's how they think. And we also have a periodontist who's been working with the desiccation therapy. Here we have bone loss. This case here, this was just a maintenance appointment where the gel was placed inside the pocket around the implant, and at 3 months, Look over to the right photo here. We had nice bone regrowth in the area. This is compelling. This is very exciting. These are nickel titanium brushes. These brushes you can attach onto the implant motor. So I'm thinking these are really geared towards the periodontist to work with, not necessarily the hygienist. I have concerns with these titanium brushes because we talked about metallosis and we talked about how the corrosion layer can come off easily. And I'm thinking if I'm working with a brush being spun around very fast, I'm going to create these titanium particles. And so I'm concerned about shards being released. But the thought here is, how do you remove the outermost layer of the implant surface? This is a study that compared use of decontaminating the titanium implants using metal curettes, plastic curettes, titanium brushes, and a laser. And the objectives, this study resulted that you got most improved surface decontamination by using the titanium brushes and the laser together. Guess what? More studies. This one's about the titanium brush and the desiccation therapy gel. And here, the gel samples, the implants were treated with the gel samples for 60 seconds. That's a much longer application. The operative time for the titanium brushes was measured. And the end result on this study was, oops, sorry about that. I missed giving you the end result on that study, that the samples were subjected to scanning electronic microscopy to evaluate surface roughness and measurement and cell viability. And this study demonstrated good decontamination and regrowth of bone. So this is exciting. So, you know, for something that was used once, we may not think it's safe now, but there's studies demonstrating alternative uses for it. So I honestly have never seen the titanium brushes used in practice, but I'm thinking if we're trying to remove the outermost surface of the implant and we're trying to graft and regrow bone in a pocket, this may be a neat direction to do more research on to see how, you know, protocol and how we make this more effective. So some of these things we as hygienists might not be doing, but we want to make sure what we are doing is safe. So let's talk about ultrasonics and piezo tips. And this is a really interesting topic here. When we're working with ultrasonic tips, we want to make sure that the tips are made of either titanium or PEEK. PEEK is polyether ether ketone. We don't want to be working with our stainless steel ultrasonic tips on implants because the stainless steel can cause gouging. This was a comparison of different ultrasonic tips in a vitro study, and the ultrasonic scalers with non-metal tips were more suitable for implant maintenance for exactly what we just said, the titanium can gouge. This is a PEEK tipped ultrasonic made by Premier. It's called the Big Easy. I see a different implant tip often in private practice. So let me explain here. This is a medical grade polymer. PEEK is polyether ether ketone. It's biocompatible. There are implant abutments made, healing abutments made of PEEK. This ultrasonic tip is autoclavable, so this tip stays onto the ultrasonic tip. And it looks a lot like the Dentsply original implant tip with the blue plastic tips. So the blue plastic tips here, they're disposable. They're meant to be a one-time use only. The plastic is not biocompatible. This plastic leaves plastic behind. And when I talk to hygienists about the blue plastic tips, I'll hear they hate it. The tips fall off. It leaves plastic behind. When I talked to the product manager of the Dentsply tip, she said to me specifically, only use this on the crown. Don't use this on the abutment. Don't use this on the implant. And my thought is, why am I using this? I could use a rotary cup to remove biofilm on the crown. So if the goal is to remove biofilm calculus from the implant abutment of the implant threads, we want to be working with a PEEK tipped. And I wanted to put this slide up because they do look very much alike. And I live very close to Dentsply, so I do see a lot of these implant tips. We really do need to be retiring the blue plastic tip and replace it with the PEEK tipped. One step worse is I see these titanium tips and they no longer have the blue plastic tips. And that, you know, when we talked about the fish bowls, you have people who run an office, they retire, someone else takes over the office. You have part-time employees, you have somebody who's been there a couple years. You have some turnover sometimes. And so sometimes people really don't know what the instruments are that they have in the office. So it's important to share with office managers, it's time to replace and upgrade this. This is no longer safe. So, I mean, have that conversation, take a picture of this article, share it with your office if you're going to negotiate replacing your implant tips. So when you're looking at these PEEK tips, they're autoclavable, they're reusable, they're biocompatible, they're metal grade. So you will see this white PEEK tip in different manufacturers. These are the tips for the Hu3D Power ultrasonic. So here's technique. When we're working with ultrasonics, low setting, low frequency, lots of water. So you want to see that drop by drop flow. And when we're working with implants, horizontal strokes. So what you're trying to do is work within the threads of the implant. So you don't want to create any gouging. You want to fit that tip in and work within the threads. Lots of water flow, low setting. All right, thank you to Premiere for that video. Polishing. You know, when I first started this, I really poo-pooed on polishing, but you know what I've grown to realize is polishing on a healthy implant, polishing the crown, removing biofilm stain is safe. We want to make sure that if we have root exposure, threads exposed, that polishing is not effective in working around exposed threads of an implant, and that we're working with airflow if there's air polishing. So here's the story. If you have a prophy cup and you do not have a prophy jet, and you have exposed threads on the implant and you want a prophy jet in your practice, the conversation goes, we don't have the right tools to maintain this patient. This patient should be referred to a periodontist who has the airflow. And you know, if you say, if I have that airflow, I can work with these type of peri-implant patients. And this is how we negotiate, how we get better equipment into our practices. So let's remember, healthy implant, no bone loss, soft tissue attachment on the abutment, we're okay to polish. If there's recession, we want to work with airflow. So if we're working with a prophy cup, we want to work with fine prophy paste. Do not use coarse prophy paste. We want to work with a neutral pH, which means if your prophy paste is acidulated phosphate, we don't want to be using that on implants. We want to work with a neutral pH. I have a list here of safe, pumice-free prophy pastes. So Proxtel, MI Paste, Soft Shine, Next Fine, Prophy Care, all safe. Air polishing. We work with a technique called guided biofilm therapy. Actually disclose the patient to see where the biofilm is. In one practice, we do this on every patient, and we will start with the prophy jet, work our way around the gingival area, remove biofilm, and then look for, if we have to work with hand instruments for hardened deposits. So, and it's well received. It's kind of interesting. It's well received, and the prophy jet's down and you don't get to air polish. Some of the patients are not happy. So air polishing guided biobiofilm therapy is actually an 8-step process that involves educating the patient, disclosing, motivating the patient, working with biofilm removal, reassessing, going over health care, and talking with the patient about their maintenance therapy. I like the idea that it's a whole process. It gives all the steps, very similar to what the British Journal gave us. All right, so if we're working with an air polisher, sodium bicarbonate, very harsh. So the molecules are very large, they're abrasive, so we don't want to work with sodium bicarbonate on dental implants. Erythritol, glycine, both smaller molecules, safe, both are antimicrobial, both are better choices for working with implants. The erythritol powder, erythritol is an artificial sweetener. It's chemically neutral, non-toxic. It's water soluble. It's got a small particle size. Erythritol is a smaller particle size compared to glycine. Erythritol is effective in reducing counts of the P. gingivalis bacteria, and the polish shows a nice smooth surface, compared to sodium bicarbonate. Also, erythritol has helped with reduction of pocket depths. So erythritol is a good choice. Glycine is a good choice. You sometimes will find a manufacturer of an air polisher will only sell one versus the other. Glycine is an amino acid. It's non-toxic. It's biocompatible. It's slow solubility in water. So this is going to stick around a little longer. It's less abrasive. It's 80% less abrasive than sodium bicarbonate, and less soft tissue damage when you're using glycine powder. So, and it says rare emphysema. So this is an adverse reaction to working with airflow. So glycine powder in some cases becomes the product of choice. So sodium bicarbonate, when we talked about the molecules being very large, sodium bicarbonate can leave a residue behind. Sodium bicarbonate is also extreme on the pH scale. There has been reports, this study was from 1990, about working with sodium bicarbonate with dental implants, causing the implant to corrode, causing implant failure. So if we have a prophy jet and the only material we can use in it is sodium bicarbonate, it's not a tool we want to use on our patients with implants. Please do not put the glycine or the erythritol into the old school prophy jets that were meant for sodium bicarbonate. The reason, the smaller molecule will clog the tubing. Don't make that mistake. Let my experience be that wisdom for you. Let me save you from that. Okay, chlorhexidine. Chlorhexidine, we know that it has a latent effect. It will acquire into the pellicle. It will release an antimicrobial effect over a period of time. Chlorhexidine has this issue that it reduces osteoblastic production. So the bone is constantly building up and breaking down, and it prevents the bone from rebuilding up. So we know that chlorhexidine can alter the titanium surface, making it less biocompatible, and it affects the osteoblastic fibroblastic production. So we now know working with chlorhexidine with dental implants is something we should be avoiding. You will see some offices start the patient rinsing with chlorhexidine immediately after surgery. There are other options. I find in the oral surgery world, they're not in tune to chlorhexidine's issues as dental hygienists. This was an article that came out in Decisions in Dentistry, and it was the myths about chlorhexidine. And one of the myths was chlorhexidine could be used on dental implants. And the answer is no, because it is an extremely high rate of cellular death to the gingival fibroblasts, and that chlorhexidine impedes on the healing process. So the body needs the fibroblasts to repair the tissue, and use of chlorhexidine reduces this. So take a picture of this article and have that conversation if your office is working with chlorhexidine. All right, so I've been talking about chlorhexidine, the mouth rinse. If we talk about chemistry, chlorhexidine gluconate is a salt. So its chemical compound is CHX. It's a salt. It's a high concentration. And if your patient rinses with chlorhexidine twice a day, the salt has the negative effects. Chlorhexidine diconate, CXD, is a polymer. And this is a low concentration that is released over a long period of time. So this is a very different way of thinking about a very similar chemical. This is an antimicrobial varnish by Ivochlor. This is Cervatec. Cervatec is a 1% chlorhexidine diconate varnish, neutral pH, and thymol. Take a picture of the QR code. This can help you get samples and sign up for continuing education about Cervatec. I think this is just the best with mucositis. And the reason is that it will prevent bacterial colonization of the oral biofilm. It'll reduce inflammation. It's a polymer. It's going to stay on the abutments where you place it, and it's going to release the antimicrobial for up to 3 months. So if I have a patient on a 3-month interval, this makes a lot of sense to help with our patients. So one of my presentations, I would show the workflow of from the Susan Grove Wood textbook about implant maintenance, and the Cervatec was part of her protocol. So I think this might be one of the better kept secrets in dentistry. So reach out to Ivochlor about having someone talk to your office about the Cervatec. When you place it, similar to what we did with the probiotics, we're going to use a small brush and we're going to place it in between the abutment and the soft tissue. And this is where the bacteria would be growing. So let's review surface treatments for a second. We talked about fluoride. We talked about fluoride creating corrosion. We talked about fluoride creating better osseointegration. And then we have these patients, the good corrosion we talked about. Then we have these patients who single tooth implant, lots of high caries rate. We send our patients home with this high concentration of fluoride. And what we're learning is fluoride, an acidic fluoride toothpaste, may modify the surface texture of the implant. So we're using a reductive agent like fluoride may actually cause issues with corrosion. So what we want to do here is when we're looking at corrosion, we're creating that rough surface on the implant. It creates an environment for bacteria to grow. It creates a dysbiosis. It can contribute to peri-implantitis. So when we're looking at our patients, peri-implant disease is a multifactorial disease. It could be placement of the implant, host response, how healthy is the body, occlusal trauma, oral hygiene, bone loss due to gingival recession, or exposure of the implant to the oral environment, and acids. So what we want to try and do is reduce all of these type of acidic pH or corrosion caused by fluoride, because we want to prevent this type of surface texture change that could contribute to the biome changing. So let me move over here for a second. We're talking about fluoride for our patients, mixed dentition, high caries rate, single implant. They're getting a lot of caries. Instead of sending them home with a concentrate, I got ahead of myself. Guys, so sorry about that. We're at the end of the class. We know from years ago with this acidulated phosphate fluoride in patients with braces with titanium wires, the acidulated phosphate fluoride would cause corrosion to the titanium wire. So we're aware that there's a relationship between the acidic pH and the fluoride. So we need to look at a balance of frequency, concentration, and pH. So if we have frequent application, we want low concentration. Over-the-counter toothpaste is safe. So fluoride in over-the-counter toothpaste, low concentration for frequent use. High concentration fluoride, prescription fluoride, frequently applied in an acidic pH, patient has a high caries rate, more acidic pH, may contribute towards caries. So our thought here is, what about fluoride varnishes? If we have a neutral fluoride varnish, low frequency of application, test the patient's pH to make sure that the oral environment is neutral. Do we have a safe application of fluoride varnish? So my thought here is, we need to do more research on this topic. Consider testing salivary pH before applying fluoride varnish, neutral fluoride varnish on our patients with implants. So there's, we really do need to do more research on this, but we do know our patients who receive high concentration fluoride prescriptions with an acidic pH experience more corrosion of the implants. So we see more mucositis, more peri-implantitis when we have our patients using high concentration fluoride. So from the home care aspect, flossing is controversial. We're aware that flossing can leave shards behind on the implant. So if we have exposed threads, we don't want those patients flossing. And we know that the shards of floss left behind can contribute to peri-implantitis. So we're not recommending flossing. We don't want to be using floss threaders. They're too harsh. They snap in between. They can affect the attachment. We want our patients working with proxy brushes. You can put the probiotic tips in, and you can see how this proxy brush will fit in better underneath this misshaped implant. Make sure that the wire is coated with plastic. So we want to make sure that it's a safe proxy brush. Make sure that the polished threads are rounded. All right, we're getting close to the end of the presentation. Tepe is the manufacturer of the proxy brushes. Tepe also has a fantastic implant care kit with all the different brushes and tools. So my recommendation is reach out to Tepe, ask for a lunch and learn. This is a QR code to win a sampler kit of the interproximal brushes. This would be a nice little benefit to the practice. So please use the QR code, take a picture of it, go through, sign up for it later. And what Tepe will do is tomorrow, they'll draw a name and they'll email out a winner to the people who signed up to do this raffle. I'm going to move on here. And the question is, brushing, flossing, oral irrigators. This was a study from 2019, and it recommended both. It recommended using interdental brushes, and it recommended using oral irrigators. And what I like about oral irrigators is we're barely touching the tooth. We have the hydraulic forces of the pulsating water removing the biofilm. Water flossing has been demonstrated to reduce bleeding 80% more than using floss. And it helps us get underneath this intaglio surface. So when we have patients with these full arch prosthetics, we're giving them all the tools to work around the abutment. We're working with those interproximal brushes underneath the full arch prosthetic. But honestly, this denture tip will help our patients get from the lingual, removing the bacterial biofilm better than any other tool. It's just smart instrument design. And we do know that our patients get a lot of calculus developing underneath the where the implants are, where the lower incisors are. So this is a great tool to work with. Here's the implant care kit with all the different tips by Tepe. I like to provide the patient with multiple options, let them try all the different brushes, tools, see what they like to work with, see how effective they are. If they're not motivated, I can get a patient just to brush. I want to see them work with something like this sonic fusion water flosser. So it's got both the pulsating action and the sonic toothbrush action. I mean, find what works best for them and works well. Okay, we're coming to the end here. Peri-implant disease is not predictable. Sometimes you can treat the symptoms and the disease can continue. I find there are fans of using bleach with water, 2 teaspoons of bleach to a gallon of water. If you do recommend this technique to your patients, make sure they understand the concentration. And the reason is that the bleach in water is very high on the pH scale. So think about swimmer's mouth and patients who are in chlorinated pools getting more decay. So risk factors, probing. Probing, we want to make sure that these are risk factors we as clinicians can impose on our patients. Probing is controversial. You could be causing more damage than good. What I mean by that is we have to have cautious probing technique. We need probe readings as a baseline, at 6 months to a year. After the mucogingival attachment has become mature, we want to have some probe readings, but we want to make sure that there's a difference between probing with too much pressure. So in probing, we want to work with 0.25 Newton centimeters of pressure. What does that mean? You're going to place the implant, you're going to place the probe by the implant. You're just basically a sweeping motion circumferentially around each of the teeth. Don't apply too much pressure. We need to distinguish, is the bleeding on probing because of peri-implant inflammation, or are we applying so much pressure it's causing trauma? And you will find there's people who don't want to see their implant patients probed because they're worried that the practitioner is applying so much trauma, it's causing damage to the attachment. So remember, implants are not teeth. We have these fibers in natural teeth causing a protection. So the probe, the periodontal ligament, is protected by the periodontal ligament. The probe will not interact to the bone. But on implants, the fibers are vertical. They're hemidesmosonal fibers. We have this nice soft tissue attachment. And if we probe with too much pressure, we can break that attachment on the abutment and the probe can go down to the bone. So we want to make sure we probe with gentle force. Sometimes the shape of teeth, they just can't probe around. They're just not reliable. So in these cases, we want to take additional x-rays annually. X-rays should be taken annually to see if there's bone loss because probing is not appropriate. I'm going to skip over this section here. This is about working with the components true to the implant manufacturer. We find sometimes people will buy from third parties and they do not fit as well. So if you have a BMW, you want BMW parts in your, in your car. If you have an implant, you want that same manufacturer's in there. So we are right at 12 o'clock, 12 o'clock. We are right at 1 hour, 8 o'clock. I'm going to stop the presentation here and open it up for questions. And we go from there.
First of all, Lynn, I want to say, wow, wow, wow. You packed in a lot. Like I have been glued to this presentation. I need to say two things. If you can maybe put up that Tepi slide again for the
Yeah,
prize,
let's do it.
because no
Absolutely.
doubt we love prizes, and I'm sure someone wants to, maybe they didn't get the QR code, would like to get that. So
Yeah.
anybody that wins it gets to share it with me, I'm just saying. And also the chlorhexidine information, kudos to you, girl, because honestly, there are still way too many doctors that are prescribing that, and the evidence is coming out showing us now that, yeah, we shouldn't be using as much chlorhexidine anymore, especially with patients post-surgery, which I myself was still prescribing with my doctor for
Yeah.
years until all of a sudden we got this article and we started doing more research on it, realized it wasn't good. The desiccation of therapy, like, wow, that information
Yeah.
I thought was so informative. And I really think hygienists today, that's why you guys are like so important in this whole role of implant therapy, because you do need to know what's going on all the time. So Lynn, I can't thank you enough tonight
Hey,
for being here and sharing us with this
this is
wealth of
fun.
knowledge. No,
This
it was amazing.
is
Are there any questions from anyone out there regarding any topic she may have discussed tonight?
I'm going to put my contact information here again.
Yeah, and you
And
also said you were going
please,
to do some handouts.
yeah,
Everyone was
I
going to get, yeah, so I think they need to hear that from you as well.
so I have notes from this class. Some of it is the quotes from the class, some of it's just, taking the quotes right from, and then some of it has some of the research articles, and then there's 3 pages of articles
Wonderful.
that I've read over time, and then the QR codes.
Okay.
So it's a nice little resource.
And
Um,
even your QR codes for all your lunch and learns, like that is just amazing. Like I think stuff like this, we need to, a lot of times, offices that I've been in practice with too, is like, well, who do we get? Who do we get? So it goes to show you that just about anybody and anyone out there will do it. And it's only to benefit the practice, nothing else. A lunch and learn is strictly to come in and provide information. So thank you again for doing the research on that one as well.
any questions? Anything show up in the chat? Oh, when it's quiet, it makes you nervous, guys.
Well, it was a lot of information. I think maybe some people still need to digest stuff. But that's great that you're going to share the information. Your contact information is there. So if anyone needs to reach out to you as well, they're going to have the liberty of being able to reach out to Lynn. And of course, you can always reach out to either myself or Tara at the ICOY. My email address is karen@teamdentaltraining.com. So I'm there to help you too. Anytime you need some additional help, or even if you want to get a hold of Lynn at your future desire, then we can give you her information too. But it's right there. Take a picture, keep her in your books, and we're here to help. One more thing I wanted to say as well, if there's no more questions. This year, because we're not doing live, as I mentioned at the earlier, we're going to be doing the ICCP program, which is the Implant Coordinator Certification Program. They're going to be running on 2 different dates, May 21st and June 4th. It may not be something that you're interested in, but perhaps you know someone if that's working towards their fellow or their master's, you may want to let them know. That is something we're offering this year for anyone that wants to expedite. But also, Sandy is in the house on April 23rd, and she's going to be talking about vaping. Like, it's going to be the ugly truth about vaping. So you don't want to miss this. Let your friends, everyone know. We welcome everyone to be a part of this. This is not just ADI members. So anyone and everyone, we want to make the ADI big and strong again. So share your information with as many people as you can. We welcome everyone. We want to let them know that we're here as an organization to support and allow your growth, more importantly than anything else. So thank you so much, everyone, for joining us this evening. Can't wait to see you all on April 23rd, and everyone else that wishes to join. Lynn, again, thank you so much for this evening.
Thank
I
you.
can't thank you enough. And
Have a
Tara,
good night.
always for your support.
You're welcome. Good night, everyone.
Night.